Yep, we've been emailing back and forth.
Okay. I have
If
to be
something
careful what I
pops up
say.
that says you're live on Facebook, you can just click got it. If it says this
Okay.
meeting stream, just click got it. And then after that, you'll need to click back onto your PowerPoint in order to advance the slides. But I'm going to go ahead and mute myself and let you get started. And we appreciate you being here so much.
Okay, thank you, Jean. I appreciate it. Well, everyone, thank you so much for joining this discussion about the Opioid Prevention for Aging and Longevity project at UAMS. My name is Naomi Armstrong, and I work at the Reynolds Institute on Aging with Dr. Wade, Dr. Azar, and Dr. Regina Gibson. And our project is actually funded by SAMHSA, along with through the Department of Human Services, Arkansas Division of Aging, Adult, and Behavioral Health Services. And of course, I do work here at the UAMS Reynolds Institute on Aging. I want to talk to you a little bit about the project, about the work we've been doing to get the word out across Arkansas to older adults, and I happen to be one of those folks, about safe use of prescription opioids and also the risk for overdose and also the availability of naloxone. I'm actually from West Tennessee, so I'm going to apologize up front for my West Tennessee hick accent. And but I come from a long line of Tennessee storytellers and drug dealers. And I say that jokingly, but my ancestors in West Tennessee, they manufactured, distributed, sold, and drank Tennessee moonshine. And so there was a lot of stigma associated with that, in the same way that there's a lot of stigma associated with opioids now. I remember as a child, my uncle, who was a lifelong alcoholic, would come to our house and he smelled like he'd been rolled in cigarette butts, stuffed in a beer keg, and left to rot in the hot sun. And my dad would go pick him up down really in an area that wasn't very good. And my dad would say, my dad had stopped drinking, but my dad would say, "Noel, have you been drinking?" And he would say, "I hadn't had a drink in 3 months." And of course, he smelled like a brewery. So those were my memories, really, of substance misuse. And so it's sort of I think my higher power must have a good sense of humor that I'm actually talking about opioids and also misuse of that. But the project that I'm working on is really about educating older adults, because older adults can be at risk for harm when they are using their prescriptions as prescribed. And so I want to talk about that today. This map that that's on the screen is a little bit of the work that we've been doing. I came to this position in 2021 in the middle of COVID, and my boss said, go out to some of the ERs and distribute some of our free educational materials about the safe use of prescription opioids. And of course, people were very busy. It was very difficult to get in, but everywhere we went across the state, people would say, opioid misuse is a problem in my community. But what they were surprised to hear is that it also affects older adults. And so I want to just kind of poll the audience, because sometimes, when I think of older adults, I always have my mom and dad's picture in my mind. My dad was born in 1915, and they have passed on since then. And alcohol was really the misused substance back then. But when you think of older adults, I'm just curious, who do you think of? Certainly not you, and certainly not me, of course, but we all qualify. So who do you think of when you think of older adults? Well, surprisingly, when I go out and ask this question, I follow it with a question about how old is Mick Jagger? Does anyone know? 80, actually. I used to ask about Tina Turner, and she has passed on. She's dancing in those stilettos now. But when we think about older adults, sometimes we forget about ourselves. I heard that 80 is the new 40, and sometimes we feel that way, but our bodies have changed and we are at risk for harm. So I call this a wrinkle in mind, opioids and older adults. So I want to poll you and just ask some questions. I go out across the state and talk to healthcare folks a lot. And I ask this question, true or false? Only people addicted to illegal street drugs are at risk of having an opioid overdose. What do you think most people think? Well, surprisingly, most people think that opioids are really only street drugs. My husband is 76 years old. He's very well educated. But when I first started doing this project and I told him I was going to be talking about opioids, and he said, "Isn't that like heroin, street drugs?" Well, yes, opioids can be street drugs, but they also can be prescribed and taken every day. Opioids are narcotics, sedative analgesics, usually used for pain, depress the central nervous system. And most people know that high doses can cause respiratory depression. People can die from that. But a lot of people don't know that in an older adult or a person with a lot of comorbidities, someone who already has respiratory issues, or they already take a lot of other drugs with the opioid, that even a therapeutic dose can be dangerous. And so we want to get the word out when we think about just some of these: morphine, codeine, methadone, oxycodone, hydrocodone. There's a lot of people take opioids and do not even know that they are taking them. And so when I say a lot of people take opioids, I got this from the Arkansas Prescription Drug Monitoring Program. They compiled the top selling prescription drugs in Arkansas from 2020 to 2022. And actually, I was surprised at this when I saw this, but at the top of the list are opioids, followed by benzos, stimulants, sedatives, hypnotics, muscle relaxants. And all of those drugs can cause harm, especially in an older adult, especially if they're taken together. I was just at a conference last week where a physician was talking about that. One of the big, when the Florida pill mills were in session, really people wanted an opioid, a benzo, and a muscle relaxant. That's what they were going for. So the opioid epidemic, this is from the CDC. Nearly 645,000 people have died from an opioid overdose from 1999 to 2021. And that may not sound like a lot, but if one of those people were your son or your daughter or your brother or sister or mother or father or grandparent, it means everything. Statistics mean nothing until they affect you personally. And I think about the very first person that I knew who died from an opioid overdose was a young man who was about a year older than my oldest son. And I had this little boy in fourth grade Sunday school. I sat next to his parents every week in church, and I saw him at a Christmas musical. And he had been working in the sound booth, and we chatted about the music and we chatted about his life. And that was on a Sunday evening, and I attended his funeral the following Friday. And I wish that I didn't know anyone who had died from an opioid overdose, but I'm betting that probably everyone on this call can name someone they know, a friend, a relative, a coworker who has died from opioid overdose. And this really came in a wave. If you look back in the 1990s, you see a big marked increase in prescription opioid overdose deaths. And there was suddenly opioids, which had previously primarily been prescribed for cancer pain or for folks immediately post-op. All of a sudden, everyone was giving out opioids. My own son had his wisdom teeth removed, and he came home with hydrocodone from the dentist, and then he came home with oxycodone from the oral surgeon. And so being a nurse, I took the medicines and I dosed them out. But and after 3 days, he came to me and he said, "Is there any more of the pain medicine?" And I said, "Are you having pain?" And he said, "No, but man, that stuff helps you sleep." And I said, "Over." And the medicines were disposed of. But there's countless stories of people who took prescription opioids for a very short time and were never able to stop taking them. And then if you look at 2010, all of a sudden there had been a crackdown on prescription opioids, and then you saw the rise in heroin overdose deaths. And now really it's synthetic opioid overdose deaths. You'll hear a lot about fentanyl and carfentanil in the community. I actually had a friend whose son had misused some medications in the past and had been in recovery and relapsed, and went out and bought a medication that he thought was a benzodiazepine, and it actually was laced with carfentanil, and he died. And so many stories, so many young people whose lives have been lost through the opioid overdose. I highly recommend, if you haven't watched The Pharmacist, it's about a pharmacist in Louisiana who lost his own son in a drug deal. His son was actually killed in a drug deal, and he had no idea that he was using. And he went on a mission not only to find the person who had been responsible for his son's death, but he went on a mission to find out more about the overprescribing of opioids and some of the pill mills that were in the area. Has a very compelling story. And then probably a lot of you, if you have Netflix, you've listened to Dope Sick about Purdue Pharma and the heavy marketing of opioids. And then, of course, you have the fentanyl and carfentanil, which really was used as animal tranquilizers. Carfentanil is 10,000 times more potent than morphine and 100 times more potent than fentanyl. And you say, well, what does this have to do with older adults? Well, because we don't think of older adults as misusing opioids or misusing medicine. But there's really three people involved when you think about older adults and opioids. One is if you are taking opioids and you may not be aware that you're taking more than one, and older adults, sometimes we forget. If you don't have a pill box, we may forget and take too much. A lot of us have hearing and vision issues, and those come into play. So people can accidentally take too much or accidentally be prescribed too much from multiple providers. But then you also have a lot of older adults that I know, they may live with someone who is misusing drugs, maybe even bringing in illicit drugs. And so the chance for coming in contact with opioids is high. And then the third person that's really at risk is children in the home. I'm an old home health nurse, and I used to go out to homes, and I would see people with their medicine on the coffee table with the bottles open or the pill box open, and they would happen to be babysitting a 5-year-old child. And if the 5-year-old child accidentally gets into their medicine, then it's really crucial that they have naloxone. So Arkansas overdose deaths, how many people in Arkansas? In 2021, 618 people died from overdose deaths. Those are probably underreported because of the way deaths are reported in Arkansas. And then in Arkansas, this is looking at opioid dispensing rates by county. As a state, we still have about double the national rate of prescriptions for opioids. And this looks at the counties where there are more opioids dispensed versus other counties. If you look at the dark red, those are the counties with the highest dispensing rates. It's very interesting that a lot of these counties are very rural, very small, and do not even have a hospital. But they very often are also adjacent to a county that has a hospital. If we look over here at Montgomery and Pike, those counties don't have a hospital, but they bump up against counties that have a hospital. Ouachita County, Phillips, Izard, Woodruff, and Poinsett. Now, this map changes from time to time. I actually borrowed this from the Arkansas Department of Health prescription drug monitoring site, and you will be able to see your county on there. So if you look at the county where the high prescribing rates are, and then we look at these two maps, which are looking at non-fatal overdoses and fatal overdoses, and you'll see again that a lot of the counties where you see these overdoses, not only do you have Pulaski and Faulkner, you kind of expected Jonesboro, but you also see a lot of rural counties. And then if you look at the non-fatal overdose rates, it's interesting. Is it because these counties don't have many overdoses, or is it because they don't have access to naloxone? And from the traveling I've done across the state, I find that the more rural the area, the less likely it is that they have naloxone available. And this looks again at naloxone administration by county. And again, you see Pulaski, we're pretty high, Craighead. If you look at Faulkner, Hot Springs area, but then you look at these small rural towns and you really don't see that being used. So what do you believe? I'm going to ask you this question. I like to have true or false questions. True or false, I cannot be harmed by prescription opioids. If I take exactly what my doctor prescribes for me, I cannot be harmed. And if there's a chat, I can't see it, but just think about it and think about the people that you know. I'm going to tell you a story because that's the best way to remember things. I have a friend who.
We're getting some folks saying false, so
Okay.
it's a little delay, but yes.
Okay, well, that's common. In fact, when I go out and talk sometimes to healthcare professionals, I will get the same answers, but that's just not true. You can be harmed by prescription opioids, and I will give you a little story behind this. I have a friend whose family member had a surgery and was in excruciating pain. The person called me and said, I don't know what to do. And so I said, well, you need to call the doctor, get this person seen. It turned out to be something that required a surgical intervention. But at the time I said, well, what is he taking for pain? And this person started naming off all these opioid medications. And I started to get my little calculator out because there is a way to take all the opioids you're taking and put in the name and the dose, and it will calculate your total morphine milliequivalents. And they were very high for this person. And so I said, well, do you have naloxone? And they said, what's naloxone? And the medicines that were prescribed by different physicians. And they also, they were prescribed every 4 to 6 hours, but because the pain was not being relieved, they were taking them every 2 hours. And the person ended up being harmed by the opioids, ended up with some delirium and ended up in the hospital, eventually got their condition corrected. But very often people, I will say, if one will do you, two will do you better, and people take too much. Or maybe they have prescriptions from multiple physicians, or they keep their medicines. I don't know about y'all, but I grew up with a family where we didn't throw anything away. So I tell the story about the widow whose husband passes away, and you take the prescription opioid to the church potluck and see who might need it, because we just don't like to throw things away. But you can be harmed by prescription opioids. And so this is a survey we did here at the Reynolds Institute on Aging. We asked about some of the common side effects, asked people, and a lot of these folks were college educated. Some of them were in healthcare. A lot of them were patients. And we asked them about their knowledge of side effects of opioids. Surprisingly, a good number of them didn't know that constipation is a side effect of opioids. So we created a flyer that said, did you know opioids can make it hard to go, literally. And then also a lot of folks did not know that opioids can cause urinary retention. They also, in addition to causing opioid overdose, they can also cause confusion and memory problems. And of course, confusion can also lead to falls. And this was a study that was done that looked at polypharmacy. And polypharmacy they define as when people take 5 or more medications. Now, I don't know about you guys, but a lot of the people I know take more like 15 medications. But this just looked at people who took 5 or more medications, and they looked at office visits, the reason for visits to the physician. And for every 1,000 office visits, 700 were related to what they called polypharmacy, interactions between those medicines. And the number one implicated medicine on that list was pain medicines. And so we created a lot of flyers, and I'm going to hold this up because we used to have these loose leaf flyers. And we finally put them in a book. It's called a toolkit. It says opioid prevention for aging and longevity, useful information for seniors. And these are available free. They have all of the flyers that I was talking about the different side effects, as well as information about some other ways to manage pain. And so if you'd like to have one of these are free. And so some of the things we want to talk to you about how you can be harmed from opioids is falls. Years ago when I was a young person, I took an opioid after a dental procedure, and I had never really taken opioids. And I went and cleaned out my car and I started to feel extremely sick. And I had to lie down on the ground and crawl into my home because that was how it affected me. Now, I wasn't harmed, but if I had been 75 or 80 years old and maybe my gait was a little unsteady, I could have easily fallen. And this is what happens sometimes. People are taking opioids or other medications, their blood pressure may drop, they get a little confused, they get dizzy, and then a fall. And falls are very often associated with mortality. And then another side effect of the opioids is, of course, confusion and delirium. It can affect your heart, can actually make your pain worse, can cause urinary retention, can cause constipation, and sometimes folks end up in the hospital from the constipation, also from urinary tract infections from the urinary retention. So this one, confusion and delirium, I want to talk a little bit about this. This is sort of near and dear to my heart. Delirium is what's known as an acute change in mental status. And it's acute, it comes on very quickly, usually in hours or days. Someone may be playing golf a few days before, and then all of a sudden they are confused or behaving differently than what they would normally. I call it the grandma is not acting right. A lot of times when folks come in with someone who has delirium, they will say, I've never heard them talk this way before. I've never seen them do this before. So it's unlike dementia, which comes on very slowly for many years. This is something that happens very quickly. And delirium is actually a syndrome. It has a number of causes. It can be caused by an infection. It can be caused by anesthesia, staying in the ICU. Usually it has a number of causes, but one of the big causes of delirium is medications. It's estimated that medications account for 12 to 39% of all delirium incidences. So, someone may have a urinary tract infection and then they're taking multiple medications that may interact, or their medication gets changed, and it's a perfect storm, really. And it really can rob people of quality of life because it's under recognized very often. So delirium is actually very common. And one of my favorite stories about delirium is actually from a famous physician, Sharon Inouye, who she's done a lot of work on delirium, and she talks about her own father, who was a renowned, I believe, cardiologist, and he had a heart attack and he was in the hospital and things sort of started to go badly. And she talked about walking into his room and he's picking at the bedclothes and he's very disheveled. He's mumbling to himself, this very well-educated man who had never looked like this before. And she talks about in one of her articles about trying to talk to his physicians who were each treating a different organ system and each very committed to getting her father well, but there wasn't really a cohesive look at that. And the interesting thing about it in her story is you see this very renowned physician walking into her father's hospital room, not as a physician, but as a daughter. And so he was very fortunate. He returned to his practice, and delirium is actually very reversible once the underlying cause is eliminated. But a lot of times it's unrecognized. It's estimated that 20 to 50% of hospitalized patients have delirium. 48% of people who go into a nursing home have delirium when they go in. 60% of the cases go unrecognized. It's often mistaken for dementia or depression or psychosis, and sometimes that can lead to inappropriate treatment. But delirium is also something that's very often associated with medications. It's costly and morbid. If you happen to have delirium, you're more likely to die in 6 months, more likely to have a fall, a pressure ulcer, more likely to be in restraints and have cognitive decline. So it's something that you want to be aware of. We also have a booklet on delirium for caregivers, just to kind of alert them to some of the signs and symptoms and some of the causes, just something to know. So predisposing factors, well, if you're over 65, you're more likely to have delirium. If you previously had an episode, if you have a lot of different conditions and diagnoses, if you already have some depression or dementia or mild cognitive impairment, if you have hearing or vision loss, and if you have a history of alcohol abuse. And then you take those predisposing factors and you add something like medicine or infection or a stay in the ICU, and it just tips the scales. And if you'd like more information about that, please email me and I'll be glad to send you more information. And so can you be harmed by opioids and other medications? Absolutely. And so my boss, Dr. Azar, actually created this booklet for physicians and healthcare prescribers called Special Considerations for Older Adults, for prescribing opioids in older adults. And opioid use in older adults can worsen delirium, drug interactions, can worsen heart conditions, affect respiratory depression, contribute to sleep apnea, cognitive impairment and dementia, falls and injuries, constipation, and urinary retention, sepsis, and of course, it can also result in death. So we have this available to prescribers who might want to have this. So you can be harmed from opioids, and I want to send you some information about that. So another question, what do you believe? And this is the one that almost always I get an answer. Older adults are never at risk for opioid overdose. True or false?
False.
False. Yay, I hear someone in the audience. Wonderful. Surprisingly, a lot of folks think that because they're an older adult and they're taking their medicines as prescribed, they cannot overdose on their medicine. That is just not true. In fact, this is a little bit old, 2020. It looks at Arkansas overdose death rates by age. And if you look at the folks 50 and older, actually about 30% of folks who are overdosing are over 50. And one of the great things they have on the Arkansas Take Back website, there's also an opioid dashboard, and you can go on this website and you can click your county and you can see people who have been revived with naloxone. And it's a really eye-opening experience. I went there today and clicked on Pulaski. And the very first, you want to know how old the first person on the list was? 63. So it's not just 23-year-olds. And these are only the people that it's getting brought to the attention. They're actually receiving naloxone and someone's reporting it. So why are older adults at risk? Well, I don't know about you, but I have a lot of pain. You wear and tear and arthritis and chronic pain. Chronic pain affects about 53% of the older population, and that older being 65 and older. Most commonly, opioids are the most commonly prescribed drugs in older adults. And they contribute to hospitalizations, emergency department visits, and deaths. And then older adults may misuse prescription opioids at higher doses more frequently or for longer duration than prescribed. They may also resort to illicit drugs when they can no longer get the prescription medicine. And then opioid use disorder sometimes can look like depression or delirium or dementia. And a lot of times folks also haphazardly take their medicines. So they become very at risk if they're going on and off. Older adults may be unaware that they are even taking an opioid, such as my friend I was telling you about, or of the side effects present, or that they are at risk for opioid overdose. I was down in South Arkansas talking to a group of healthcare folks about naloxone, and they told me a story about a lady in their community, and she had been prescribed naloxone along with her opioid medication because the push had become for physicians to prescribe it when they prescribed an opioid, but no one told her what it was for. So the home health nurse went out to see her, and Mrs. Jones, or whatever her name was, said, do you have any more of that allergy medicine? Because naloxone is a nasal spray, the one that we are giving out. And she thought it was an allergy medicine and had just taken all of it. And so they may not even be aware of what it is or of the need for it. Again, also older adults can live with someone who's using opioids. I call that shopping in grandma's medicine cabinet. And as a home health nurse, I've seen this quite a bit. And then history of alcohol or drug use in the past. Sometimes we don't ask the right questions. And I think as healthcare folks, sometimes we assume that because someone is older, that maybe they haven't ever used illicit drugs or haven't misused prescription drugs, or we don't ask too much about alcohol. And so that is changing some. And of course, vision and hearing and memory problems. I myself can barely hear. I have hearing aids, and I imagine that if you can't hear the pharmacist explaining the medicine to you, if you can't see the label or you get the label mixed up, or sometimes people just forget. I forget. And then they may have kidney or liver problems that impair how they metabolize the medicine. They may be using long-term opioids, and we go to a lot of different doctors. You know, the older you get, the more doctors you have, and the younger they are. And sometimes get medicines filled from multiple pharmacies. And one of the other big things I see is really what I call transitions in care, when the patient goes from the hospital to maybe a rehab facility, and then they go home, and then they go back. And that is a really risky time for medicines getting confused, for medicines getting communicated among the providers. I was down in another place in Arkansas where one of the physicians said when their patients from that rural community come to Little Rock, it may be 3 weeks before he's even aware that the patient has actually been in the hospital. So patients may have a generic form of their opioid at home. They may go home with a brand name prescription, and they don't know it's the same medicine, or they have, multiple opioids and they don't know that they are all opioids, so they take them all. And so people accidentally are harmed sometimes. So older adults are at risk, and here's just a few of the reasons. One, we don't metabolize things the same we used to. We have a lot of pain. We may have kidney or liver impairments, which make it difficult for the body to break down the medicine. A lot of folks may already have sleep apnea or chronic lung disease or heart failure, so they've already got respiratory problems going on. Vision, memory, and hearing, and mental health issues. Just because we get older, if we have mental health issues going on, they don't go away. In fact, getting old is not for the faint of heart. There's a lot of loss in becoming an older adult. We lose friends, we lose family members, we lose what we do for a living. Sometimes we lose ourselves, we lose hearing, we lose vision. And it's a hard thing to adjust to. Then polypharmacy, we just take a lot of medicines, and we are always at risk. This is just something you can look this up online. I usually throw this in for the healthcare folks. There's a lot of different opioid medications, and some of them are listed here. I think it has codeine and hydrocodone and fentanyl and morphine, oxycodone. But each one of them has a conversion factor. And so there's these little calculators that you can get on your phone now, and you can type in the name of the opioid you're taking and the dosage, and it will convert it to morphine milliequivalents, equivalent dosage. And what they've found is that people who take more than 50 morphine milligram equivalents per day, the risk for overdose is doubled. So the more opioids you're taking, the higher the dose, the more likely, the bigger at risk you are for overdose. So signs of an overdose, and this seems like there's lots of videos out there. You can go out. There was a wonderful documentary that was put together. Dr. Gorey was in that, and he talked about, I think it's 7 days. I think the title of it is 7 days. It talks about if people who take opioids for 7 days in a year, they'll still be taking them. But there's also some family members and some people who have recovered who are talking about overdose, and there's actually some videos. But when you think about an older adult, especially if you're taking care of someone, an elderly parent, difficult to wake up. Snoring, raspy, gurgly, choking sounds, shallow breathing, blue, gray lips, fingernails, and skin, clammy, sweaty skin. But if you're taking care of an elderly loved one in your home, especially if they have a lot of comorbidities, how many of these things do you see every day? I remember patients I've been to see who, may have had heart failure or COPD and a bunch of other comorbidities. And, some of these symptoms I might see in them every day. So it's important that the caregiver be alert, be aware when there's a change. I'll tell you that story later. So what do you believe? Has anyone ever told you that taking prescription opioids with certain medicines or alcohol can increase your risk for an opioid overdose? True or false? And that is true. And it goes back to those age-associated changes in excretion of drugs. And this little booklet, be glad to send it out to you. This was Dr. Azar put this together. It's for providers, but we sometimes give it out to lay people too. There can be an accumulation of the metabolites of morphine that can cause respiratory depression, sedation. And then oxycodone levels can increase by approximately 50% in folks with renal insufficiency. So you may be taking a dose that otherwise would be therapeutic, but the renal insufficiency causes that to increase. And then gabapentin and pregabalin, a lot of times they're used for neurogenic pain. They need special dosing. And those drugs actually potentiate the effects of opioids. You also have something, polypharmacy, we were talking about earlier about we're taking a mixture of drugs. A lot of drugs are broken down by the same enzyme in the liver. And so the more of those medicines that you're taking that are broken down by that enzyme, the bigger chance you have of increased half-lives and a buildup of those medications. So what do you believe naloxone is a medicine used to reverse the effects of an opioid overdose and restore breathing? True or false? It is true. And it's readily available. And I'm going to give you some. In fact, after this presentation, however many people are on the call, I'm going to drop this off at your site. We are giving this out. Now, naloxone comes in multiple methods of being given. There's injectable, there's nasal, some can be given sub-Q, but the one we are given is actually a nasal spray. It's a 4 milligram nasal spray, and each box that we're going to give you contains 2 doses because naloxone will reverse the effects of respiratory depression, but the opioids stay in the body longer than the naloxone. So someone can actually re-overdose. If they've taken a lot of drugs and you give them the naloxone, you may revive them, but they may need another dose. They may need multiple doses, especially if folks have taken a whole bunch of drugs. But we've found this to be very effective for folks. My boss, Dr. Azar, had a patient who was 80 years old who saved her daughter's life with this medication. And I was out talking to another group a few weeks ago, and a young lady told me about at a hunting lodge. They had a person who was there at the hunting lodge who they thought was asleep. And then they took a closer look and noticed that he was turning blue. And they were 30 to 40 miles away from any kind of help, any kind of medical help. And there happened to be a sheriff that was patrolling the area who stopped by and happened to have this kit and saved his life. And I've heard a number of stories about folks saving someone's life with an Narcan kit. I believe Kirk Lane, the former drug director, has a story about saving someone's life in a Las Vegas airport. And so we want to give this to you. So naloxone saves lives. And how does it save life? Well, it is an opioid antagonist. It attaches to the opioid receptors and reverses and blocks the effects of opioids, including respiratory depression. That's a big thing. It only works if the person took opioids. If they've overdosed on something else, it's not going to be effective. It's not going to harm them, but it's not going to help them. Naloxone can restore breathing in 2 to 3 minutes. It has no effect on someone who's taken something else. And as I tell you the story about the lady who thought it was a allergy medicine and took all of it, it did not harm her. It can safely be given to people of all ages. It does not produce a high. It's an opioid antagonist, so it has the opposite effect. It's safe and effective with no risk for abuse. And the wonderful thing about the nasal spray is anyone can administer it. If Dr. Azar's 80-year-old patient can administer it, anyone can administer it. And so we developed a little flyer for this. So if you came up on someone that you thought maybe had overdosed, one of the things you want to do is you want to, we put the steps in here. You can give them a sternal rub with your knuckles against their breastbone. Call 911. It's very important that they get medical help. We also, in our kit that we provide to you, we also have gloves and we have a CPR mask. We want you to protect yourself as well. And you want to take the nasal spray, put it in their nose. You put your fingers on either side of the nasal dispenser and use your thumb to push the plunger and give them a dose. You want to make sure they're on their back. And then you're going to wait 2 to 3 minutes. And if they don't revive, then you're going to take the other dose and you're going to give them the other dose in the other nostril. If they're not breathing and you know CPR, you can give them some rescue breaths or some chest compressions. You want to put them on their side in recovery position. And the reason you want to put them on their side is because one of the things that happens when you administer naloxone is they could have projectile vomiting. So if someone's lying on their back and they vomit and they swallow the vomit, then they can aspirate. And then you want to make sure that you get them to medical care. Because giving naloxone can cause withdrawal symptoms. And also because you're not sure what they have taken, the naloxone can wear off and they can re-overdose. That actually happened to someone I know who was revived, taken to the hospital, and then died. They'd taken a lot of different kinds of drugs. And you think, well, okay, I'm not going to remember this, but what we did was we took this little flyer and we laminated it and we put one inside every kit that we give out. So the instructions are there on how to use it. Again, this is I think from the VA. Again, you just peel back the nasal spray from the box. And then here's a picture. If you look in the middle of the screen, there's a picture of what it actually looks like. And you put your fingers on either side of the nozzle, and then you're going to put it in their nose. So your fingers are actually up against the nose, and then push the plunger. You don't want to prime it because you would lose what's in the dose. And you're going to tilt the person's head back, provide a little support under the neck, put the nasal spray in the nose until your fingers are on either side, and then push the plunger. And if no reaction in 2 to 3 minutes, then you want to give them a second dose. Naloxone stays in the body for 30 to 90 minutes, but opioids stay in the body much longer. Once the naloxone wears off, the opioids will reattach to the receptors, and that's why they can overdose again. So a second dose may be necessary after 2 to 3 minutes. And for some of the emergency medical folks, depending on what someone has taken, they may give much more than just 2 doses. So it's very important that you get medical help. Also recognize that when you administer naloxone, when they wake up, they may become combative. So on some precautions, just a thought, if you see someone you think has overdosed and you administer it, you cannot harm them, but it's not going to help them if an opioid is not what they've taken. And then abruptly reversing the effects of opioids can result in a pain crisis if it's someone who has accidentally taken too much and they were taking it for pain, and you administer the naloxone, it can cause their pain to go into a crisis. And then also abrupt reversal of opioid effects with someone who's dependent on opioids can cause withdrawal symptoms. And those are things like nervousness and restlessness and body aching all over, weakness, diarrhea, stomach pain, fever, chills, goosebumps, vomiting, and some folks may become combative. So just be prepared for that. Then we want you to report the Narcan use. Don't run, call 911. Most of you have probably heard the story of Joshua Pauly and how that act came about. It was a young man, I think at UCA, who had been taking drugs with friends, and he overdosed, and his friends had some substances or paraphernalia on them, and so they just left him to die. And so they passed the act, Joshua Pauly Act, that says if you assist someone with naloxone, even if you yourself had substances on you, you would not be arrested. So we want people to don't run, call 911 and give the naloxone. And then there's a place where you can go and report it. And we also put that little flyer inside the kit so you can report it if you have to use it. Number one, we want to educate patients and caregivers. We have all of these free educational materials available for you. Lots of booklets. There's the one about I was talking about on delirium. Then we have one on over-the-counter medicines, falls, stimulants that may be in your, you may be taking stimulants and not know it, and opioid use disorder. We also have these coloring books. I want to send you some of these. These are very, I get lots of requests for these. It's art therapy. And because sometimes when we color or involved in music or art, it is a great way for relaxing, a great way to improve our hand-eye coordination and other fine motor functioning, and just relaxation. Also, the toolkit that I was talking about earlier has a lot of information about integrative therapy, some information about ageless grace, exercises you can do from a chair, the importance of exercise and eating well and hydration in managing pain. These are a few other ones. We have optimal management of pain through nutrition and hydration. There's the toolkit. And then we have a booklet on naloxone on the way. This is the Narcan mobile app. There's a lot of resources on this site about how to use Narcan, also where to find treatment and support. And I want to send you all these free materials. And if you don't need them or you don't want them, please share them with someone else. I also want to remind you, we have the Arkansas Drug Take Back coming up. We will be doing that here tomorrow. They do it twice a year. And people can bring all of their unused medicines, not just opioids, but anything they've been saving for, in case the world ends. You can bring it up here and dispose of it safely in the big green box. I think UAMS, the Reynolds Institute on Aging, took back. We were 6th in the state for collecting unused medicines. It happens every year. And if you miss it tomorrow, there are places all over the state where you can go and dispose of unused medicines. These are just some of our places we've been. We had classes here at the Reynolds Institute on Aging when we first started. That's Dr. Gibson. And we've been to lots of conferences. We've carried the message around the state. This is an Arkansas Drug Take Back. And over the just in this year, we have distributed over 3,000 naloxone kits across the state, and we'd like to continue doing that. This is our map of where we've been, and we're still out there. So if you know people who want more information, who'd like to have some free kits, who would like to have us come talk to them about any of these subjects, we are happy to do that. If you just email me, I'll be glad to. We also have billboards and bus ads. You can, if you're around the state, you may see one of these from time to time. And we have been to every county in the state. Here's some of our partners. And we continue to reach out across the state. This is from the federal visit that we had. Our mission, of course, is to continue to get the word out both to healthcare providers and also to older adults and their caregivers. And Dr. Way said, we went from having 114 opioid prescriptions per 100 people down to 71.7 opioid prescriptions for 100 people in the state of Arkansas. Now, we can't take credit for all that, but we think we've made a difference. And we hope you will reach out to us if you'd like more information.
Well, between all of the work that your group does and the health department does and folks in clinics across the state, I hope that number continues to drop. Really, really important information today. Thank you so much for sharing it. And we love having your slides. And I hope that we can put this on our public Facebook page so more people who tune into LifeQuest can also access this information. Would that be all right with you?
I think so. And please, I do have my email, I think, on one of the front slides. So if
Okay.
anyone wants more information or they want more kids, if they will email me, I'll be glad to get those out to their organization.
I know we would appreciate having some of those at LifeQuest and your flyers, any information that you would like to distribute to older adults. That's our group. So our average member's age is 75, and we'll be happy to get those into as many hands as we can.
Perfect. And I'm excited to be old enough to join the LifeQuest party and listen to other people talk.
Absolutely. There's no minimum age, but we are geared toward retired adults, but we welcome you to zoom in with us at any time. And I appreciate your husband's question toward the beginning when he asked, well, what does this have to do with older adults? Well, I think you sufficiently answered that and gave us a lot of great information and food for thought. So, and I appreciate also knowing if you administer naloxone and it's not for what we thought it was, you're not causing harm by doing that. In addition, I think that's an unnecessary barrier to perhaps saving a life. So
Yes, and you never know when you're going to need it.
right, great information. Well, we look forward to getting some of that into some of our members' possession and distributing the information. So thank you so much.
Thank you so much. I appreciate it.
Excellent program. All right, we look forward to spreading the word.
Thank
So
you. Bye-bye.
Appreciate it. Thank you so much. Bye-bye.